Hello, everyone. Welcome to Cornea Frontiers. Today we have Dr. Alexandre, who's an ophthalmologist and a cornea specialist. Dr. Alexandre has special interest in cornea, ocular surface disease, and he currently is an assistant physician in the cornea and external ocular diseases sector of the Federal University in Sao Paulo. He's also the head of corneal transplant sector at the hospital Santo Amaro in Sao Paulo, Brazil as well. Thank you so much for being here today. Take it away.
Thank you so much for the invitation, everyone. It's a pleasure to be here speaking to you about a topic that I'm so enthusiastic about. And so let me share my screen to
So while you're sharing the screen, today's topic is going to be on corneal tattoos. So it's going to be really interesting because it's an area he's passionate about and he practices. And I mean, I follow him on Instagram and I see all the lovely photos he posts. So hopefully we learn a lot today. Thank you so much.
Yeah, it's very nice to see that through internet we can spread our word and our job to the world, right? So it's really nice to see that it has come to you from across seas, and this is the result, right? To be here speaking to you now, and this is very, very interesting because the knowledge I have, I've learned with others as well, and we can never stop sharing and learning, so that we can develop every time more about the topics and the techniques, right? So it's very important to share this knowledge. So I'm going to show you a little bit about the history and what I've been doing here in Brazil regarding the keratopigmentation technique, which is basically to put pigments in the cornea to change its appearance, right? So when we talk about keratopigmentation, we have to think about factors that must be considered, because we have to remember that although there is like a blind eye behind that leukocoria or something, there is a patient and there is something going on there. So we have to analyze their symptoms, the visual prognosis, the aesthetic appearance of the patient, anatomical and functional changes, eyelid or eyelashes abnormalities, dry eye or keratinization, the age, and the general state. This is very important to understand. So what's going on with that eye is not just get a tattoo machine and color whatever that it's there. So this is important to observe. The keratopigmentation is a technique described for hundreds and hundreds of years. It's not a new technique, but the main problem probably was the material used, the quality of the ink, and the difficulties in making sure that it was safe for the patients. And Dr. Samuel Ziegler is considered the father of the modern keratopigmentation. He started developing and studying and publishing other new ways of doing the keratopigmentation, and his main research was published in 1922. And then Dr. Jorge Alió in Spain, another ophthalmologist, kind of developed more recently on other studies. And so it's it's not new, but there is uh, not enough literature, so it's still fresh.
Yeah.
The pigments we use is, well, in Brazil, I use generally tattoo ink or ink for micropigmentation, like for eyebrow pigmentation. They are here in Brazil registered with Anvisa, which is um, the sanitary agency from Brazil, like the FDA in the United States. And
Mhm.
according to Anvisa, they have to be like sterile, atoxic, non-carcinogenic, biocompatible. So it's already demanded that these products should have all those characteristics that makes them safe to be used in the human body.
Mhm.
So therefore, I can use it in the cornea, although it's like an off-label use.
Yeah.
It is safe. So those are the products I've been using here. But I do it on the operating room, like it's in a surgery, right? So everything's sterile, the patient anesthetized and in a sedation, and so it's a really controlled situation because I have to imagine that like a corneal perforation can happen during the procedure, and I must act immediately if that happens. So
Yeah.
um, the products, they are um, uh, they have in their label the the CIs, which is the color index of the pigments being used. This is
Yeah.
important to understand because there are pigments that are organic and pigments that are inorganic.
Yeah.
I can use both of them, but they have different characteristics. And Dr. Georges Alliot most recently found that inorganic pigments are more indicated to be used because they will be more inert and fade more slowly. So it would be more interesting to use uh, pigments that are inorganic. The pigments that are inorganic all starts with 7,7. So in this example, I have only organic pigments, for example. So
Yeah.
this is nice to be and to know. This is another pigment that I don't use in Brazil because I don't have it, but it's very interesting because it's a pigment developed by this laboratory by Biotique Fosséa from France. They have developed and registered an implant uh, for keratopigmentation. So it's specifically designed to do this procedure. It's very, very interesting, but it's not available in Brazil. And it's too expensive, so it's impractical for me to use, but it's already designed to that use. So the keratopigmentation techniques that I've learned and that I most often perform are these techniques that were designed by Dr. Georges Alliot and published in his book in 2015. Um, that he basically divides in the superficial keratopigmentation and intrastromal keratopigmentation. The superficial keratopigmentation can be manual, like with a needle manually puncturing the cornea, the stroma of the cornea, or it could be automated using a tattoo machine that will be more like effective. Or I can do intrastromal techniques that are manual, so I can do like a tunnel in the stroma, dissecting the stroma to inject the pigment in this tunnel. Or I can use the femtosecond laser to create that tunnel for me, and then I implant the pigment. So here's some examples. The superficial manual keratopigmentation pigmentation will be uh, basically micropunctures in the superficial layers of the stroma using a needle, and the maneuver is repeated until adequate amount of pigment is introduced in the superficial corner. You can see that it's not such a complete cover of the cornea, and but it's effective if you don't have other possibilities or to do some details, or you can use it as well as to complement the other techniques. The superficial automated keratopigmentation would be to use a dermograph or a tattoo machine to do those micropunctures. So it's a machine with a pen, and this pen is connected to a cartridge full of needles. And then they have, you can set the machine to whatever speed of puncturing, and you can also control how much of the needle is going outside the tip of the cartridge. So the depth of the punctures also can be controlled.
Okay.
This is an example of a cartridge with you can have cartridges with 1 needle, 3 needles, 5 needles, 7 needles, 12 needles. So it's up to your experience to decide which format, which kind of cartridge you want to use according to the patient or the technique used. So you sip the tip of the cartridge in the ink, it absorbs the ink, and then like a Zevator, and then you can apply on the cornea, and it's much more effective, but sometimes it can be too aggressive for the cornea tissue, so you have to be careful. This is an example of me doing it with 2 different equipment in the operating room. And you can see that it's not very complicated, but you must be careful because you can in these situations perforate the eye or have kind of bleedings, or so in my opinion, this should be done in the operating room with everything sterile and controlled by an eye doctor.
Yeah.
This is some histological studies that Dr. Alior has published, showing the depth of the needle according to the number of needles used, the kind of cartridge. So if you use a 1 needle cartridge, the 1 needle goes a lot deeper because it's only 1 needle. It can perforate a lot easier. If you use like a 5 needles cartridge, you have more superficial tension, and then it's going to be more superficial because you have more difficulty in penetrating the tissue, and then you have a lot more superficial punctures. And these are some examples. This was a very, very damaged eye. It had an enormous edema, so a very soft tissue of the cornea. And it's interesting because these patients normally have a lot of symptoms. Their eye hurt because of the bullous keratopathy. So when you do the keratopigmentation, it also they also get better because it forms like a fibrosis, and it's like a micropuncture technique to treat the bullous keratopathy, but you use ink,
Yeah.
so you treat and you also color and makes it
Cosmesis.
better. Yeah. Another interesting use of the automated keratosis pigmentation is to make shades of color. So in this case, the cornea was normal, clear cornea, but she had a white cataract, and her iris color was dark and had darkened. So, and she had like this beautiful green eye. It was very difficult to get to this, like the most difficult part is this, to find the right colors to resemble the other eye. So in this case, I have to mixture lots of colors and do like some shades around the pupil. And another case, very interesting, like 3 months later, was this case. I had some difficulty to like the cicatrice, the healing was not very easy, but in the end it was very nice and the color was very satisfactory. So it's these patients, they become really happy after the procedure because it's really life-changing. The other technique about the intrastromal keratosis pigmentation would be to create this tunnel and hi, are you here? So to create this tunnel, and we can use a crescent knife, a micro crescent knife, or any sort of blades to dissect the tissue of the cornea and create this tunnel in the superficial stroma of the cornea, and then you can inject the ink to color the cornea. The problem here is that you don't have, you can't do what I did in the last case, like creating shades in different colors.
Yeah.
You can put
Yeah.
basically one color and it will fill the tunnel uniformly. So you can even change a little bit. You can see in this picture that it was like too light, and then he darkened a little bit the brown, but
Yeah.
it's difficult. The ink gets stuck in the stroma, so it's not that easy to mixture colors once you've injected it. This is a case I did. uh, I didn't have this micro crescent knife at the time, so I used a blade. So you can do, like, you can adapt with whatever you have to create this tunnel, most uh, very superficial tunnel, so that the remaining stroma, superficial remaining stroma, still is still transparent. So in the end, it's you can have good results. Uh,
Yeah.
you can also do it in patients that are not blind. So in this case, it was an iridectomy, and then the patient had this not only a static problem, but you can have like double vision, monocular double vision. So one alternative is to do a sectorial intrastromal keratopigmentation. Just a part of the cornea is pigmented. Another case,
Yeah.
post-traumatic iris loss. So you can also recreate the iris using this technique. And the histopathology is like that. You have a very regular ink, uh, line in the anterior stroma. And it's interesting to see that there is no big inflammation. The ink is inert inside the tissue. Some cases that I've done here in Brazil. So this technique is mostly preferred when the cornea is more transparent, or there's not so much alterations in the ocular surface. Otherwise, it will be very difficult to dissect the cornea. Also, in patients with corneal transplantations, for example, or big scars in the cornea, it's not recommended. Here's the video to show you that you have to prepare this eye first. So you have to cauterize big vessels and to do some kind of keratectomy to remove deposits or lesions that are above the cornea. So in this case, the patient had some hyperepithelial hyperplasia, and this had to be removed prior to the pigmentation. Otherwise, it would be a worse result, I think. Right. So after I removed it, the cornea was very nice underneath it, and then I did the keratosis pigmentation. I dissected the tunnels, and injected the ink. You see that you can inject and clear and clean it afterwards, and it's the ink only sticks to damaged issues, so it won't stick on the preserved conjunctiva. Yeah, if you have any cuts or any entrances here in the conjunctiva, the ink can go underneath the conjunctiva and pigment the sclera, so you must be careful. So 2 years after the pigmentation, it's important to notice that blind eyes normally are already in some kind of atrophy or phthisis. So it will evolve regardless of the keratopigmentation. So the keratopigmentation itself, the pigments are permanent, but the general aspect of the eye, you can't guarantee that it will remain for the rest of the lives, right? So it's important to notice that these eyes may develop other degenerations or atrophies, but the general result of the pigmentation is very satisfactory for at least over 5 years. So this is another patient that had a clear cornea, and she had this this yellow deposit inside her eye. I don't know exactly what that was, but since the cornea was clear over it, I did the tunnels, and the general aspect is very nice. And another interesting use is for leukocoria. So this is a white cataract, and the clear cornea. I just did the tunnel to create the pupil, and the result is awesome. So you can use the tunnel techniques when the cornea is more clear and more and it doesn't have much problem. And you can also combine techniques. So you can do, for example, the tunnel on the pupil, and then you can do the superficial technique over it or around it. Normally you have to prepare this eye. So this had a band keratopathy. I had to remove it. So, and mix the colors. This is the most difficult and very important part, to get to a more realistic result. And this will be the result. And also in this case, for example, I had an decimetal cell. I don't know how to say that in English, actually. And so it was decimetal cell, yeah. It was almost perforating, so I couldn't just get here and do the the keratoconus pigmentation because it would perforate. So what I did was to do the keratoconus pigmentation around this area, and in the same time do a corneal patch here to fix the cementocele so it wouldn't perforate. So a cornea surgeon can have this maneuvers to handle the problem. This is another very interesting case that she had a corneal ulcer, and then she had to do a very large decentrated corneal transplantation that consumed part of her sclera, and she had this aspect, and since she had lost part of her sclera, I pigmented not only what would be the cornea, but I pigmented the whitish, pinkish part of the sclera, and then I covered it with the conjunctiva. So the final result was very, very interesting. And you can also use the femtosecond laser to create the tunnel and to inject the ink inside. So this is basically the technique used to create a tunnel to insert corneal rings, but adapted to do a larger tunnel. So normally the set of the femtosecond would be an inner diameter of 5.5 more or less inner diameter, and the outer diameter 9.5, and then you dissect this tunnel, you open it, and you try to push it to the limbus so that it will cover this outer part that the laser didn't get. And you have to remember that these patients normally they have vision, so they may need to operate the eye for a cataract surgery, for example, in the future, or to be examined. So you must have enough space in the pupil to do it. So once you dissect the tunnel, you inject the ink, and this is a case, for example, of an aniridia. It's a traumatic aniridia in a 12-year-old girl. She had a lot of photophobia, and then doing this technique, you create the tunnels, inject the ink, and create, instead of inserting an iris implant inside the eye, you can create the aspect of the iris using the keratoconus pigmentation. Other cases of essential iris atrophy, you just remove the iris atrophy and create the iris in the femtosecond laser. This is Dr. Alios's work. And there is also the purely cosmetic use of the keratoconus pigmentation. This is something that has been published in 2015 by Dr. Jorge Alió. I think it was his creation, this technique, that would consist in doing the femtosecond laser technique and implanting whatever color you like, so that it can change the aspect of your eye, purely cosmetic. This is now being doing for I think many other countries in the United States, in France, in Spain, and I've seen another. I don't know if you do it, but if this is being doing, normally they use the French pigment that has been developed specifically for this purpose. So in Brazil, we don't do it yet because the legislation here is a little bit more complicated. And I think first we have to prove that the technique is safe and develop a proper pigments for the cornea, so that maybe we can try and do this purely cosmetic techniques. But I think it's very interesting, and but must be looked carefully, because it's normal people with normal vision that we are going to interfere in their cornea. So we have to be careful if to see if there won't be any complications in the future, right? And also you can adapt other techniques. So if you have a very disfigured eye, you can perform, for example, a lamellar transplantation of the cornea associating with the keratosis pigmentation. So this is the case where we did a very large corneal lamellar, anterior lamellar transplantation, and you pigment underneath the lamellar transplantation. This is a case from Dr. José Álvaro Gomes from São Paulo. It's a very interesting option in some cases. And this is this is what gives us the motivation to do this. It's when you see a young patient that sends you pictures of her looking at the camera and smiling, and that's something that she never did it since she had the problem of the eye. So the figuration of the eye is something that affects deeply in a person self-esteem, and to perform this, it's completely life-changing for them. So this is really what gives us the reason to change. She says, you changed my life. These photos, I always had the hair covering half of my face, and now I'm free and super willing to live. So this is really grateful. And well, to end, I would like to share with you that last October, we did the first course of keratosis pigmentation. So we started to try and develop this to other ophthalmologists in Brazil that are not familiar to the technique. So we have this weekend course of training in theoretical and practical, and it's a very I mean, we did it in Brazil, but it's very possible that we can have foreign courses, or with foreigners coming to Brazil as well, and do this in English, for example, specifically. So we're trying to develop this and to let the world know the procedure and learn how to do it and train it. So if you want to send me a message, if there's anyone interested about learning the technique, we can try and arrange a specific course. So thank you very much. This is my Instagram, Dr. Shiz, if you want to follow, and I'm open to any comments or discussions. It will be a pleasure.
Thank you so much. Muito obrigado. This has been really lovely. I'm sure we all learned some things. I mean, I had a bunch of questions to ask, but after listening, it's like you've answered most of my questions. Well, I'll just go ahead and ask a few ones. So in your opinion, looking at the different techniques, whether you're looking at the superficial keratectomy method, or whether you're going to do a lamellar method to introduce the ink, what would you say would be, what are the pros and cons? What are the advantages and disadvantages of each of these techniques?
Yes, when we talk about the superficial, the advantage is a little bit more controlled. Yeah, if you have a manual superficial, you can really control where you're going and how deeply you're going. If you use the machine, it's a little bit it's more effective. It's more dense pigmentation, but
Yeah.
it's a lot faster, so you don't control. It's like 60 punctures per second, so
Oh, wow.
per second. So it's very, very fast, and sometimes you can uh, you have to be a little bit more skilled not to uh, do something wrong. Um, and
So
also
on the
another,
average,
sorry.
yeah, go ahead. Go ahead. No, go ahead.
Another advantage is of the superficial techniques is that you can do like shades of colors and mix colors to create uh, uh, an aesthetic aspect more likely, more resembling the other eye with
Okay.
details.
Yeah.
And a disadvantage of the lamellar tunnel technique is that you normally have only one color fulfilling the tunnel.
Mhm.
Uh, an advantage of the lamellar interstromal technique is that you only have basically one cut or a few cuts in the cornea, and then you
Mhm.
dissect the trauma. So you almost don't traumatize the cornea. And so the post-operatory recover is a lot better, a lot less pain,
Mhm.
and faster. So this is a very good advantage. And the ink remains there really stable. Um, and when you use the superficial, the demograph or the machine, you have
Yeah.
to remove all the epithelium first, and then you do the keratosis pigmentation, and then this epithelium has to grow over it, and it can take a while, or it can you can have some kind of fibrosis or risk of infection. So it's a more complicated post-operatory procedure.
Yeah. And on the average, I'm assuming with the superficial technique, you would have to place a bandage contact lens on the eyes until the cornea reepithelializes.
Yes, normally I use contact lens after the procedure, so
Okay.
it will um, be less painful for the patient, and I normally leave the contact lens for at least 1 week.
And with the lamellar technique, have you found that, I mean, I'm assuming you don't have to put a bandage contact lens with the lamellar technique, but are there cases where you may have had to suture
Sorry, could you repeat the question, please?
the incision, or you just
Yeah.
put the bandage lens technique? Have you found, or have you had any cases where you had to suture the incision, or maybe use a tissue adhesive to close the incision, or put a bandage contact lens over it?
No, normally you don't have to suture. You just I put the contact lens normally and for safety. But there was one case where when I was teaching my student to do it, and when he was going to perform the incision to start dissecting, he put too much strength and then he perforated the cornea. So I had to suture the cornea because of that. And but then I could also get on and finish the procedure. But that is something that
Mhm.
can happen very easily if you're not I mean, if the cornea is too thin, or if you're not careful enough to with that. So it could be. So that's why I always do that in the operating room normally.
And my next question would be, what's the, on the average, how long does the procedure take?
In general, I take like an hour and a half to do the procedure if you have uh complete, like if you have to do the whole cornea. If it's a sectorial part, it's faster. but normally I plan 1.5 hours for each procedure.
Okay. And again, I think one of the biggest questions on everyone's mind when we hear about corneal tattoos is how long does it last? When would the color start to fade? When would it become obvious that the pigments are fading away? And does this vary with the technique?
Yeah, it normally the intrastromal pigmentation is more um more normally it's more stable, so the color um is more difficult to fade, but um it really depends on the person and on the situation of the eye prior to the surgery. So it's impossible to say how long it will last. The ink is permanent, so the ink won't dissolve, or it can suffer a little changes in the color, in the shade of the color, because of the sunlight, because of the time. But um, eh, like a skin tattoo, it lasts all your life. It can have
Yeah.
some changes, but it will last unless you have some kind of infection. So I've had some patients, for example, that developed herpes in the post-operatory. So the stromal herpes would just uh, removed all the central pigments, for example,
Pigments.
and then like after 1 year I repeated the procedure, treated the herpes, and I could manage it. But if you have an infection in the cornea, the infiltration in this trauma because of the infection can remove the pigments. And so in generally you can expect for at least 5 years of a good result. And in this time, the eye can change a little, can atrophy, can get a little atrophy, can turn to a side or the other, or can create calcium deposits like band keratopathy. So
Yeah.
this can change the aspect of the eye, but the pigmentation itself is expected to last long.
And are there certain cases where you would say, which you would say it's contraindicated for corneal tattoos? For example, are there certain patients who present to you who want the procedure and you would advise against it?
Um, yeah, there are some cases you have to put and see if it's worth it. For example, I have a patient that had 5 corneal transplants. She had keratoconus. She had 5 corneal transplants, and she had 4 rejections. So the 5th corneal transplantation was successful using immunosuppressive
Right.
drugs. And then, so she's finally seeing with that eye, and she's bothered that although she's seeing with that eye and had a successful transplant, the border of the outside of the
The
cornea of the
graft
outside of the
junction,
transplant is
yeah,
whitish.
whitish.
Yeah, because of the rejections she had, and she's very
Mhm.
uh,
Understand
dissatisfied.
about
She's not satisfied with that, so she wants me to tattoo outside the transplant.
the
So
host.
in this case, yeah, the host. So in this case, I mean, is it really worth it trying to do that? Because if I do it, and maybe I will start
Trigger a rejection.
another rejection. So some cases are not just not worth it. You just,
I,
and it must be careful with thin corneas not to perforate it. So you can do it, but I mean, you always have to put what's in game there. So if it's a blind person, it's a blind eye, and it's risky to perforate the eye, for example. Okay, it's a risk, but the eye is already blind, and maybe the person wants to take that risk because for him, her, this is important. So it could be done. But if it's a person with vision, you must be a lot more careful because some problem would damage the vision. So
Yeah. And in cases where you have an intraoperative corneal perforation, how do you handle those?
yeah, I would basically try and suture it, or if it's something that I have planned before, I could take a donor cornea for safety, or to do some kind of patch or some
Right.
tissue. Um, uh, if so, I can work with a donor tissue if it's necessary, if it's a risky cornea. So if not, I just try and suture and see if it gets stable, to see what to do next.
And in managing the patient's post-op, maybe you have a case of delayed reepithelialization or some other form of ocular surface disease. Do you ever have to use amniotic membranes?
Well, I've never had to use it, but it is something that is possible. Actually, I have a patient to be operated soon that has a very symptomatic bullous keratopathy and uh, a very painful blind eye. So I'm really considering to do the pigmentation and to cover it with an amniotic membrane. I think it would be a lot more efficient to treat the symptoms of the pain, and I don't think it will um, damage a lot of the general aspect of the color, because the amniotic membrane is so thin, and so it's a good option when the cornea is symptomatic. Or I've had some cases that had like zero sensibility corneas, and so you or that had already had some kind of neurotrophic ulcers. Then you're gonna do the pigmentation, and then you expect that that cornea won't heal well. So in these cases, you can predict it, and you can use the amniotic membrane like preventively in the end of the surgery. It's a good option, yes.
Yeah. And would you say, again, with as with all things, I expect there is a learning curve. But how many procedures would you say that an average corneal surgeon would have to perform before you sort of get a hang of it?
Mm, well, it depends on the on how trained you are as an eye surgeon. So I mean, I started doing keratopigmentation when I was already a corneal surgeon, so it was a lot easier for me to get to to do the techniques, because I had already some kind of training in cornea surgeries. But
Yeah.
I would say it's not too difficult, especially if you use the superficial techniques. It's a lot easier to get the handle of it, and um, but it's very, I mean, it's very advisable to have an experienced cornea surgeon beside you to handle any
Okay.
possible complications that you may have as a perforation, or any kind of ocular surface problems in the postoperatory. I mean, the technique itself is not that difficult, but the managing the postoperatory is something that has to be has to be careful because sometimes it surprises with difficulty in epithelialization or infection or herpes, for example.
Yeah, yeah. And my last question would be about the last case you shared about the young lady who was happy and it changed her life. Now, do you see this a lot in the patients that you see, the change in their quality of life, improvement in confidence and things like that?
Yes, exactly. This is this is the main reason why I do it, because this is so life-changing for these patients. They have suffered a lot because of the problem that got their eye blind, and they normally have already
Mm.
had done a lot of surgeries, and it's a really deep pain for them, and they usually hide from society. They don't get jobs, um, they don't have partners. It's a the minority of them that overcome this and really show themselves to the public. So this is when they do it, they are so grateful that this changed their lives and this got them back to, it's like a rehabilitation. Like, so I have this feedback from almost all patients. It's
Mm.
and this is so um, this gives us motivation to keep doing it and trying to enhance the technique to get every time a better result or more realistic result.
I mean, it's really wonderful to hear these stories. I mean, I fit prosthetic contact lenses, and the patients are usually very happy after the procedure. So I can imagine how it is with a cornea tattoo as well. Um, do
Exactly.
you do you have patients who come in with contact lens intolerance as a reason for cornea
Yeah.
tattoos?
Exactly. I was going to say that right now because it's basically the same effect as you have when you adapt a color contact lens or a prosthetic eye.
Aye, yeah.
Yeah, but many of these patients cannot use a contact lens or or a prosthetic because they get pain, they feel a lot of discomfort. So in these cases, eye keratosis pigmentation is well indicated if the patient is very well adapted with the contact lens, so that's fine. But a lot of them have eyes that are already in atrophy, for example, so the contact lens is like
Will not fit.
slippery and it doesn't fit properly. So the keratosis pigmentation is a good option.
Oh. Um, Thank you so much. This has been really enlightening. I'm sure we've all learned. I'll put up your Instagram page if people want to reach out to you for training, have questions or whatever it is. I'm sure you'll be happy to reach out, give them that feedback. But thank you so much for sharing your knowledge and keep up the good work. Thank you so much.
Thank you very much. It was a pleasure for me. We're in touch.
Yeah.